By way of disclosure, I have to admit that this was not my title. I thought it was very, very much of a bummer, so I'm going to try and give you a little bit of hope. But that being said, on the 16th of March this year marked 1 year since I and my family returned from a wonderful vacation in Mexico to a totally changed world. And this was my attempt at a haiku for the feelings I had at the 1 year point. Well, today's goal is the question, another lost summer, but I want to provide an update on the pandemic, on COVID-19 vaccines, and maybe a little bit on how the pandemic ends. And the answer to the question, another lost summer, is it depends. All right, so our quick update on SARS-CoV-2 and COVID-19. Well, this is the data from this morning. We have had now 4 different waves. The last one has not been a hurricane, but more of a little bit of a drizzle here in the upper Midwest, but it's still ongoing. But overall, you know, we've had 148, almost 150 million laboratory confirmed cases and over 3 million deaths across the world. United States, we're up to 573,000 deaths. And I want to just remind you that coronaviruses have a significant mutation capacity. They're an RNA virus, and because of that, they undergo more mutation than our DNA viruses. Fortunately, coronaviruses have an enzyme to correct some of the errors in transcription, but it opens the door to new variants out there, for which there can be natural selection for transmissibility. If we do a quick comparative anatomy between the great pandemic of 1918-19 and the current COVID-19 pandemic, boy, a lot of similarities, except this one I think is worse. And I want to just put in perspective that 1918-19 was before we had oxygen as a supplemental agent, before we had antibiotics, before we had intensive care, before we had any vaccines, except for the smallpox vaccine. So a very, very different world. And despite all the medical care we have, it still has been devastating. And that devastation not only is realized across the population, but it's realized with a great deal of disparity. So for example, in the first 6 months of 2020, on average, Black men lost 3 years of life. Latinx men lost 2.4, and Black females lost 2.3 years of life. But overall, everybody, on average, lost about a year of life in the United States. I'm going to jump over quickly to some theoretical framing. And when I'm talking about vaccines, I really want everyone to keep in mind that vaccines are just part of the picture, that no one intervention is going to get us out of this. It's the interventions combined that have been very, very successful at this point in time. And indeed, vaccines have been wonderful. But the way vaccines will work for this pandemic is if we can get up to this mystical peak known as herd immunity or the herd effect threshold. And this is just theoretical, but if we assume we had to get up to 60% of us immune, we can get there through natural immunity, becoming infected and recovering, or from vaccine-induced immunity. And in this example, we're saying, we have 25% natural, we need 35% from vaccine-induced, and then we get there by multiplying the vaccine effectiveness by the vaccine uptake. This is pretty simplistic, but it works, all right? Well, this is where it falls down. The B117 viruses have really taken off in the United States here, shown in the peach-colored circles. And in fact, they have now amounted to about 50% of US cases. So this is that variant that emerged in the United Kingdom and has become the dominant strain in the United States at this point in time. This is important because this is a more transmittable form of SARS-CoV-2. A wonderful graphic from a JAMA article back, I believe in January, that shows the basic reproductive number. Basically, the number of new cases generated on average per case across that x-axis, and the herd immunity threshold needed to control. And it's a pretty simple mathematical relationship between these two. Where the variants come in, and for example, in this, they're showing SARS-CoV-2 as having a reproductive number of about 2.4, a 60% herd immunity threshold. What happens if we have variants that push that basic reproductive number upward? We also have to compensate by immunizing more people or getting more people immune. So if we go back to our diagram and pushing this up to 80% now, we need much more vaccine-induced immunity, or we can try the Swedish model and try and get more people infected, but those certainly have significant consequences. I wanted just to think for a little bit in terms of how we compartmentalize our population. And we tend to think of our population as being this kind of unified thing out there. So if we start with transmission risk with an R0 of 2.3, we think about masking and distancing, and we look at consequences of hospitalization and death. I'm going to argue that's probably not the way to think about it. In fact, we probably have multiple populations, and for the sake of simplicity, I'm breaking it down into two. Think about a high-risk group out there for transmission that have many more transmission events per case. These are people who are not compliant, they're low masking, they don't like to distance, and they, in general, have lower consequences. Because of age, because of other factors, they may have lower morbidity and mortality. We then will have the low transmission risk group. And in fact, when cases get into this, they tend to stay there. They don't get transmitted on. They have a very low realized basic reproductive number. These are people who are very compliant with masking and distancing, but have, and I have an error here, this should say high morbidity and mortality, so much higher consequence. And then if we go a step further and say across the population, we have a 10% laboratory confirmed infection rate. And our overall estimated infection rate might be 30 to 40% because of the people who aren't being tested. Well, in fact, what happens is most of those infections occur in that high risk group and very few in the low risk group. But the low risk group has that lion's share of morbidity and mortality. Well, do we have evidence of this happening? Since August, my research team has had the contract to do surveillance on the UW campus. We have had about 1,000 faculty, staff, and graduate students enrolled in surveillance. And it turns out that faculty, staff, and grad students on the UW campus have a phenomenally low rate of infection. The overall prevalence for this group has been about 1.5% over this entire period. At the same time, our student body is somewhere around 40 to 50% infected. So these things really do happen out there. So I want to go back to our model here. We can look at this high risk, high rate of infection, low vaccination group, and the lower risk for infection with a low rate of infection, high vaccination rate. And we can kind of think about what happens. We have now enough data out there to show that the longer term, we can't say long term yet, but longer term protection from infection is at least 80%. The estimated real world protection from vaccination looks like it's about 90%. This is really good. And in fact, if we look at what's happening in our own backyard, Dane County, we have now had about 44,000 people infected. And keep in mind, this is just the people that we know about. And in general, we tend to think that number should be somewhere around 3 to 4 times that. If you look in that red box, though, you see that the infections have been generally younger individuals, really peaking out in that 18 to 22 age group. Now, if we look at vaccination, phenomenally, in Dane County, 57.7% of us have received at least one vaccine dose. And these vaccines are incredibly effective. But unlike our infection, the vaccination really is skewed toward the older individuals. So at the end of the day, if we were to kind of do a back of the envelope calculation, we can come up with perhaps about almost 3/4 of our population here in Dane County are now protected either from prior infection or from vaccination. And that's really, really good news. We're getting up toward that herd immunity threshold. All right. I'm going to jump over and just talk a little bit about evaluating vaccine safety and effectiveness. Long and short, everything that went into these vaccines in terms of the safety assessments and effectiveness were no different than what we expect from any other vaccine. The safety was thoroughly assessed, and I can actually tell you that compared to most other vaccines out there, the sample sizes were much, much higher than we usually see. In terms of the effectiveness, the estimates were able to be achieved very, very quickly simply because the studies were being done at a time of phenomenal transmission. If you think back to last October and November, we were just really accelerating. And this allowed the accrual of cases in both the vaccine and the placebo arms to occur very quickly and achieve those thresholds that we needed to assess the effectiveness. The HIP came through very quickly after the FDA and made that very first recommendation, now seeming like a long time ago, of December 13th. And very quickly, the safety apparatus got turned on into the post-authorization phase, or started looking for adversity out there in recipients. And as everybody knows, the big one for the mRNA vaccines have been anaphylaxis, at about one case out of every 400,000 or 500,000 individuals vaccinated. And more recently, we've heard of the vaccine-induced immune thrombocytopenia. I'm only putting up this flow sheet for you for reference. I think this is going to be distributed across the department. But the other thing that's really even as important is if you think you see anything like this, to make sure you report it into the vaccine adverse event reporting system. This is the way we know about these events occurring out there. But in general, all the vaccines have been remarkably safe and incredibly effective. So I'm going to just move quickly and talk a little bit about the end of the pandemic. And when I talk about pathway to the pandemic's end, we talk about a pathway, not a highway. We have not been over this before. We don't know which way it's going to bend and turn. And sometimes we don't even know what the destination actually looks like. So keep that in mind. And in fact, sometimes the way to get there can be really, really complicated and hard to follow. I'm happy to say, though, in this diagram, in the very middle are primary care providers. So at least some of us think that's really, really important. Well, the vaccine is currently flowing across the United States and in a phenomenal way. Fortunately, it also is slowing down a little bit. We had the pause of the Johnson & Johnson, but unfortunately, we're starting to see more and more individuals turn down the opportunity to get vaccinated. And this is really, really unfortunate because this is such an important component to our way out of the pandemic. When might we as a country achieve herd immunity? It depends. At the current pace, it could be sometime in mid-summer, perhaps August. The good news is that we are starting to look at information on our work group on the pediatric vaccines, and we're hoping that by June or early July that we have recommendations out there for age 12 through 15, and the younger children will follow. But this is all very good news. But the bad news is here. And this just takes a little bit of time to digest, but the x-axis here is the percent of population vaccinated. And it's divided into three groups out there: the least, the middle, and the most vulnerable counties by social vulnerability index. And each of the circles is a county across the United States. I think we have about 3,300 counties. The thing I want to point out is Dane County, Wisconsin, our very own backyard, has the highest rate of vaccination in the country. This is probably for multiple reasons, but this comes with privilege. It comes with access. It comes with acceptance. And quick, for example, if we go up to the most vulnerable, I don't know if you can see my pointer, but the dot right here is Milwaukee County. So 70 miles away, and we drop down 10 percentage points in vaccination. Again, access to care, acceptability of vaccine, and all those other things we know that create disparities. We not only have disparities at home, but we have disparities across the world. And right now, India is getting a lot of attention, but it's just one of multiple low-income countries out there that are having devastating effect. For your information, India has an overall vaccination rate or coverage rate of 2%. So how does this end? Do we have another last summer? It depends. In Dane County, I think we're sitting incredibly good at this point in time. Many of us are vaccinated. I think we're going to be at herd immunity. We're going to have a good summer. But the rest of the world, we have to consider that this is a global pandemic. We have to keep our eye on the variants of concern out there. Those are things that may escape vaccine coverage. They may increase transmissibility. They might increase the morbidity and mortality. Eventually, SARS-CoV-2 is going to become our fifth seasonal coronavirus, and it's going to be subject to the seasonal and year-to-year ebbs and flows that we see with all the other respiratory viruses. Vaccination or revaccination will likely be needed because of waning immunity and the escape variants out there. Masks may become much more commonplace during respiratory virus season. Masking and distancing has been incredibly effective for almost all the other respiratory viruses out there. And so we might be seeing these in healthcare facilities and in schools. Other reactive mitigation measures might be employed. So preemptive or reactive school closures, as an example. And then we have to have our attention to the negative long-term consequences and collateral damages of COVID-19. The people with post-acute COVID-19 syndrome, the spotlight we have on health disparities that Shiva is going to be talking more about, the neglected and put off healthcare, and the economic and emotional devastation out there. This is just the final lines from Catherine Ann Porter's Pale Horse and Pale Rider, 1939, but one of the very few pieces of American literature ever written about the 1918-1919 pandemic, where the houses with the shades drawn, empty streets, the dead cold light of tomorrow. And I'm going to finish up just with something I wrote back in November for a web commentary about the pandemic of 2020. Unfortunately, it's not going away soon, and it's going to be with us for months. But I'm hoping we get through it. I have a lot of confidence and good feeling about Dane County and our own backyard. I worry about a lot of other places. So I'm going to stop there, and we'll have a thoughtful discussion after Shiva comes on. So thank you very much, and I'm going to turn it on over to you, Shiva.
Great. So thank you so much, everybody. Tough act to follow, Dr. Temte, but I'm going to talk to you a bit about the racial equity issues with COVID-19 vaccine. And I also come to work every day with the positive thoughts of the work that can be done to really create racial equity. So I'm going to try to actually tell you a story about the great things that have happened right here in Dane County and the work that's being done. But first, I want to ground us on thinking about what the key issues have been that have created both a disproportionate impact of COVID-19 on our communities of color here in the US, and also around access to vaccine and lower vaccination rates. So one, we all know and have seen and read a lot about the disproportionate impact of COVID-19 on our communities of color, specifically Black, Latinx, and Native American communities. And really the fact that that is really grounded on the fact that we continue to see systemic racism create a fertile ground, I would say, for disproportionate impact of disease on our communities of color, including higher risk factors for our communities of color, which again, we saw play out very unfortunately throughout 2020, and we see that continue. Then we have the issues of trust, and this is one that again we saw as an issue during the beginning of the pandemic, with the trust about whether the information was correct, whether people should actually access care, testing, and we've seen it very much so in the conversation around vaccine, around COVID-19 vaccine. And it really has to do with the historic and current experiences with racism in healthcare. And I really want to kind of emphasize historic and current, because oftentimes we think about this as like, oh, it's about the history of racism that happened, the Tuskegee trials. But we hear from our communities of color a lot of current experiences that they have that really are racist experiences within healthcare. And that is an experience that happens to them regularly, and therefore their trust that they have in our system is really questioned every time they have that kind of experience. Of course, education and engagement, and making sure that education and engagement happens in a racially, linguistically concordant manner, so that there is really a sense of belonging and creation of trust. The location of where both, again, services were happening during testing, during the height of testing, and right now where vaccine is being made available are important. And the last piece is access. And this is one that I consider the most critical in the work around vaccine. As much as people were talking about the hesitancy and really trying to, we say that we have had lower uptake of vaccine because of trust issue, what I have seen in my day-to-day work is that the biggest issues have been around access, actually, for our communities of color. So at the beginning, the scarcity of vaccine, and then the decisions that were being made about like who was getting vaccine really created some access issues for our communities of color. Creating systems that were based on privilege. So privilege of having online access, being able to really make appointments online, the privilege of being able to kind of what I'm calling the grab and go system that was happening before, now vaccine has become really available, but it was like you would put your name everywhere, and then you would grab the first appointment that was available, and you would go wherever it was, whatever date it was, because you could prioritize vaccine over anything else that was happening in your life. And that in itself is really a system of privilege that many of people in our communities of color were not able to certainly even think about taking advantage of. Language barriers continue to play out, and the location. So one of the most interesting pieces of data that I saw was a survey from the Kaiser Family Foundation that surveyed people, including Black and Latinx, about where they would feel the most comfortable getting their vaccine. And guess what? People said their clinic. They're actually a clinic setting. Confirmed everything I was thinking about, but really certainly questioned the idea that if you made the vaccine available everywhere, people would just go to wherever it was available. Actually, the people that we wanted to reach the most, our people in Black and Latinx community, were saying they would really, the majority of people would prefer to get their clinic at a trusted place, and that trusted place happens to oftentimes be their primary care home clinic, the community health center, and then of course they also mentioned their local pharmacy. So with that, now some data about where we are as far as vaccination disparities. First, the data from just overall state of Wisconsin. So as you can see, just a quick snapshot of the data as of yesterday is that we still have a gap. Certainly our Black Latinx community are lagging compared to our white and non-Hispanic. But now, watch this, Dane County. So this is a good story. I think that Dr. Temte talked about how, we really do have a good story here, but what's even more interesting is that we even have a good story relatively, okay? And I'm just, again, as I said, I try to keep positive because the numbers is still that there is disparities. Our white non-Hispanic have a higher vaccination rate than our Black, Hispanic, and Asian. But compared both to the state data and the national data, we are doing better. I want to highlight specifically that we're doing a lot better for our Latinx data. And I want to give thanks to Dr. Tejas Giron, one of your own faculty member, and the work that the Latino Health Council has been doing, because this work has come through 24/7 really focus on both engaging and giving information to the Latinx community, and then getting actually people in to get appointments and in a place that they trust. And the same work we've been really doing also with our Black and Southeast Asian community, and I'll talk about that a bit more. So one other data slide that shows you the trend over the past 4 weeks. And so what, of course, you want to see is the sharpest increase possible, because it really kind of tells you about whether, we're continuing to really see a good uptake of vaccine. And as you can see, we, definitely the rate is slower amongst our Black and Latinx community. And then interestingly enough, we kind of are seeing a little bit of the slowdown of the white non-Hispanic trend in our area. So now I want to walk you through a story of what we have done as UW Health to center racial equity since the beginning of availability of vaccine. And I tell you this story because I think it's really important to understand what real action around racial equity can look like, and how when we decide that we really want to prioritize a center racial equity, that we actually see results in the work that we are doing. So back in December, when we first got our vaccine allocation, and when, of course, the eligible group were healthcare workers and residents and staff of long-term care facilities, we decided at UW Health that we were going to prioritize vaccinations of UW Health frontline staff using, of course, job-related exposure, so who had the highest level of exposure, But we also said, let's add age and social vulnerability index to that. So that if you have the same level of exposure, but you are either older or have a higher social vulnerability index, and we only have one vaccine available, that we make sure that we're using an algorithm that prioritizes those who are at most risk, because the data did tell us that people that are older and have higher social vulnerability index were more at risk for COVID-19. So this was a very innovative way that we looked at how we would allocate scarce resources within our own employees. This is, for those of you who are very data-driven, this is what happened when we applied the algorithm. So what the algorithm really did, actually did have an impact on how our employees of color were prioritized in receiving the vaccine. So important work within, again, our own employee group to prioritize SVI and as part of SVI racial equity. Then the next group happened, which is, okay, now you get to vaccinate your 65 plus patients. And again, at this point in time, we still had vaccine scarcity, right? So we didn't have enough vaccine to be able to get all of the UW Health primary care patients that were 65 plus vaccinated. So the decision was made internally that we were going to actually prioritize our Black, Latinx, and Native American patients that were 65 plus to receive their invitation in the first round of invitations for vaccine. This ended up producing this result amongst our patient population of 65 plus that were vaccinated. So again, it works. As you can see here, we ended up having really very much closer data as far as the uptake among our Black, Latinx, Asian, White, and American Indian patients, because we made sure to again, the first round of invitation, invite all of our Black, Latinx, and Native American 65 plus. And then we proceeded to invite our white patients by age groups, so older to 65. And that gave immediate access to people who, again, the way the system was working, otherwise we're having really difficulty finding an appointment, finding the time to find an appointment, and we're being left out. And then here's what we've been at since March 1st, and have continued to do work around this. We're employing 4 different strategies to make sure that, again, we continue to reach out and work on uptake and access for our communities of color. We've done a lot of community engagement and education in collaboration with Public Health Madison, Dane County, and the other health systems, developed joint materials with, again, public health and the other health systems in both English, Spanish, and Hmong. We are doing an average of twice a week. We have forums that we're doing in many different settings in the community, from parent groups, at the Verona High School with, again, Dr. Tejas Firon and I did a forum for them on Monday, to the Boys and Girls Club is having a forum in a couple of weeks. So in any setting, any place that we're asked to have this kind of forums of information and education. The key to these forums has been to really bring trusted providers that are trusted by the communities, and really have worked within their communities prior to COVID, right? So they're not people that are new to the community, but people who have been engaged within their own communities for a long time. We also have created the vaccine equity days. So these are days that we are dedicating at our 1102 South Park Street, site of the Wingrat Clinic, to schedule patients that are Black, Latinx, and Southeast Asian that are referred to us through community partners. So we are having 1 or 2 days per week where we are keeping that schedule and really scheduling those individuals who are being referred to us, to our community partners. This has been an incredibly successful way for us to reach out really deep into the communities, and have somebody that's really trusted, a community-based organization, contact their people they serve, get the names to us, and then we are contacting those individuals very quickly, giving them appointments at a site that is very well known to everybody in the Madison area and communities of color, that's easily accessible. And we're also providing transportation when people need it, and we have interpreter services available on site. So it's been really extremely successful. People have told us that they really trust coming to the clinic. And that again confirms what we heard through the Kaiser Family Foundation about people really wanting to be at the clinic. It makes it feel official. It makes it feel like it's a place that they can trust. The third strategy is our mobile vaccine clinics. We have done at UW Health done very limited number of mobile vaccine clinics, but Public Health Madison-Dane County have certainly started to do more and more of them. And we have partnered with a couple of community-based organizations and are thinking about continued partnership in doing small mobile vaccine clinics, specifically partnering with Quartz Badger Care Plus, so that we can reach out to all the Badger Care Plus members and get them vaccinated. And then the last one is our vaccine patient educators. We at UW Health have hired vaccine educators that are really community health workers, 2 for the Latinx community, 3 really for the Black community, and 1 for the Hmong community. I know some of them are joining us today, so welcome to this forum, and thank you for the work you're doing. They're reaching out one-on-one to the medically home patients that we have in these groups and identities, giving information, educating them, and then helping them navigate signing up for a vaccine appointment if they're ready to get their vaccine. They have blocked spots so that, again, they have easy access to make sure that those that they're talking to have their vaccine appointment right away. I will end with this quote from one of my favorite authors, which is Dr. Abraham Kendi, about the fact that I feel like COVID vaccine is going to be either the way that we redeem ourselves as a community and as a society from the disproportionate impact of COVID-19, or we show that we're going to continue having systems that really have persistent structural racism within them. So I want to prove that when we really center racial equity, we really can make a difference, and that we are going to respond to the incredibly disheartening, disproportionate impact of COVID-19 by having the highest rates of vaccination possible amongst our Black, Latinx, and Native American communities. I will end it here so we can open it up to questions for both Dr. Temte and I. Stop sharing.
Wonderful. Thank you so much, Shiva and John, for that. So we'll go into the question again. Please populate in the chat, and I'll moderate the questions. So I think the first question will be to John. When will FDA officially approve the vaccines? I think to get at this, currently they're under emergency use authorization. And are there studies examining the vaccine effectiveness to prevent spread?
Yeah, for the full vaccines, I believe the companies, both Moderna and Pfizer, have started the process now. So I would expect those by middle to late summer to go through all those hoops. That's a very, very minor thing in my mind, because we have such an incredible usage of the vaccines at this point in time that we have incredibly good evidence of both the safety and effectiveness of the vaccines in real life populations. So in many ways, the basic licensing application process is formality, but I think it is important for some people. In terms of other questions, some of the best data we have being protected from not only infection but spreading comes from healthcare providers, where in some health systems people were vaccinated very early, but still ended up being tested on a weekly or at least a regular basis. And that would be the way of finding those individuals who have asymptomatic infections. And it turns out that those are actually very, very low. So I think the real world data that I provided for you in terms of the effectiveness is coming from healthcare providers, and it's at least 90% effective in preventing either asymptomatic or symptomatic spread. And so these have been really, really good vaccines along that line. There was one more question I think that Jonas had that I'm going to jump into very quickly, and that deals with the long-term effects of vaccines. And in reality, stuff is the long-term adverse effect from a vaccine. When we look at vaccines, almost all the adverse events occur within about a 42-day window. In terms of anything immunologic, we're not going to get a delayed event that's occurring months or years down the line from vaccine. These occur early on in those first 6 weeks. There's only one thing that I know of that would be considered a long-term effect of a vaccine, and that would be antibody-enhanced infection. So by providing a vaccine to somebody, you prime the immune system to respond worse to that infection later on. And I'm happy to say that we have not seen any of that with the COVID-19 vaccines at all. About the only vaccine that really has a bad track record for that has been the dengue vaccines. So I think it's really important to explore what people mean by long-term effects. Certainly, the people who are having venous thromboses can have long-term effects from that, but those are occurring, 6 to 14 days after vaccination.
Great. And Shiva, I was really struck when you showed the Dane County numbers, just the uptake by the Native American at 90%. And just wanted to see if you could comment on that success and what we could learn from it. And then I see also that Danielle Jancy is joining us. Thanks, Danielle, for your comment on outreach in Baraboo. But Shiva, if you have any comments on.
Danielle responded perfectly as somebody that, so they're really the outreach in Baraboo. And I would say the fact that the tribal health got their vaccine allocation directly from the federal government and were able to really focus and be able to vaccinate to, again, a trusted place, right? Their own Baraboo did an amazing job. So their own kind of providers within their own tribal health. And so that's an incredibly great success story. And that took a lot of work and really 24/7 work in the community by trusted people in the community to get the vaccination rate to be that high.
Great. Shiva, there are a couple of questions coming in on, one is around transportation. How do we get patients to the Wingra Clinic? And then are there also COVID vaccine navigators available for patients outside of Dane County that you know of?
So the transportation, I was typing and because I know we're going to run out of time. So there is, if there are patients that need transportation, I think we should, again, use the regular ways that we have to assist patients with transportation. If it's for the vaccine, through the vaccine educators, again, the vaccine educators are able to access ways to try to make sure that they help with transportation. I want to be clear that the vaccine equity days that I was talking about, so the vaccine educators are able to schedule vaccine at any of the sites that offer vaccine, not just at the 1102 South Park Street. So wherever it's most convenient for the patient. The vaccine equity days that I was talking about, those referrals come to us from community-based organization. Those don't have it, like many of them are actually not patients of UW Health, which doesn't matter in our vaccine outreach. And we provide them transportation if they need to. But there are referrals that come to us directly from community-based organizations. And then I think it was vaccine educator in Dodge County. Is that what the question was?
From Dr. Peterson, yeah.
So the vaccine. Yeah, Mary may be able, since she oversees the vaccine educator, she may chime in, but they're reaching out to UW Health primary care home patients that are Black, Latinx, or Hmong. So regardless of what the site is or where is it that they are receiving their care. So independent of which clinic they are receiving their care. That helps answer.
Okay. And there, maybe John could comment on the safety of vaccines, pregnancy, and in breastfeeding women.
Well, as it just so happens, April 23rd, New England Journal of Medicine had a report out there. There, we're trying to center that. And I haven't even had a chance to read carefully through this, but real quick, as of the time they did the review, February 28th, there were over almost 36,000 women who had received the vaccine while pregnant. And the conclusions are that there are no obvious safety signals in pregnant persons. This is always a difficult thing because we will not have any randomized controlled trials assessing pregnancy. However, in the run up to the, basically what we call a phase 0, when they're doing animal testing of vaccines, they're looking at fertility, they're looking at pterogenicity of vaccines and so on. And because these moved on into human trials, the assumption, well, not only that you can assume that those were negative, and in reality they were negative. There were no signs of any fertility or of any fetal development or other. The good news is babies who are born to mothers who have cord blood positive for antibody, and there is evidence now that at least in mother's milk during lactation who have been vaccinated, there is antibody for COVID-19 as well. Whether or not that's going to be a very effective way in terms of mucosal antibody, we don't know. But right now, all the signs are pointing towards safety in pregnancy.
Great, thank you. And Shiva, back to you, the question came up with from Dr. DC. Has there been any intentional efforts to cooperate and collaborate between healthcare systems in Madison-Dane County in providing vaccine outreach to BIPOC communities?
Absolutely. Actually, we have a group called the BIPOC Community Engagement and Education Work Group that has a representative from each of the health systems. So SSM Health, GHC, Access Community Health Center, UW Health, and Public Health Madison-Dane County. We meet on a weekly basis, and we have developed joint materials, FAQs, and also anytime we get requests for like community engagement and education, we're kind of sharing it amongst us to see who can do it, which one of our providers can do it. We also have created a video of those FAQs in Spanish and in Hmong, specifically for the Black community and the Spanish-speaking Latinx community that hopefully will be done by the end of the week. And then we actually, through Public Health Madison-Dane County, there is also a sharing of the mobile sites and what requests people are receiving, and then different health systems are signing up literally for them, saying, and I can do this one and I can do that one, so that one, we're not duplicating, and two, we're really collecting all of the different information about the request for engagement and outreach. So lots of collaboration, which I think, by the way, is part of the reason of our success also in Dane County, is that we really are really collaborating, and we continue to hear that that kind of collaboration is not happening in other places, that it's very unique to see all health systems and the public health department meet weekly and share information very openly and collaborate to make sure we're reaching out to into the community.
Great, thank you. John, could you comment on where Wisconsin is in terms of overall goal towards herd immunity relative to other states?
Well, we're not quite as good as Dane County, but Wisconsin is in the top tier of states. We're near the top in terms of the number of vaccine doses that we've received being administered into patients. And so we're doing quite well. I haven't looked at the actual number in a couple of days, but we're probably in about the high 40% of individuals who have received at least one dose. And again, Dane County is almost 58%. So this is all boding very well. My concern out there right now has been the level to which people stop accepting. And I really laud Shiva and Patricia and Danielle out there reaching out to communities to enhance that acceptance. I think when I saw this actually just the other day and seeing that Dane County is at the top of the nation, it really is an attestation to, it takes a village mentality. We're all working on this together, whether it's one-on-one in our exam rooms, or if it's through outreach, or if it's through a health system, really advocating to their patients. But this is really important. And unfortunately, I worry about some counties, some communities, some other places that still take this as a serious event. And even driving in this morning, listening to one of the northern counties, I think Taylor County, Wisconsin, where the school district has voted to remove masking from students because of parental demand that this happens. And this is at a time that, unfortunately, the children are in a group there that have no vaccine and have very low infection due to everything we've done before now. And you're just opening up the doors for things to spread. So we're not through it yet, but we're getting closer. And I'm hopeful, but I think it's not time to let down any guard.
Great. We just have time for one or two more questions. Let's see, we do from Kirsten, Dr. Reinfush. Do you have any recommendations for key messages that clinicians can use to reach people who have been hesitant but remain at least somewhat open to vaccine?
I'll answer from my perspective. I think a couple of things. For me is asking them whether they know somebody that has gotten the vaccine and opening a conversation that way. We know certainly in our communities of color that what really tends to make a huge difference for people is whether somebody in their circle has received the vaccine. So based on what that experience was, then having the conversation, like if they say, yeah, and the person got really sick, then explain, why and why does that happen? Or if they didn't have any, symptoms, and we talk about it that way. And then the biggest, most important message that we certainly have seen makes a huge difference is the fact that vaccine is not just about you, it's about your family and it's about your community. And that is what really resonates with our communities of color, because the impact of COVID-19 wasn't on individual, it was on entire communities. People can tell you, I had their uncle, a family member, everybody almost can tell you they had somebody close to them, even if they didn't get COVID. So I think thinking about it the same way, it's not just about you, it's about protecting everybody that you love.
And I think when we start talking about some of the collateral damage out there, paper recently, last week out in Pediatrics, identifying roughly 40,000 children under the age of 18 who have lost at least one parent during this pandemic. Every person out there who has died of COVID, every person who has been hospitalized, every person who's been sick at home or lost other things because of this got their infection from another person. And I think we have to just emphasize that what keeps this pandemic alive is that person-to-person spread. And whatever we can do to interrupt that spread is so essential to prevent those deaths, the hospitalizations, the loss of parents, and so on across our population. So I think we really need to talk not only about that first dose for the mRNA vaccines, but the second dose or the Johnson & Johnson vaccine, getting that first dose in, and not only for yourself, but for your population.
All right. Well, we're up against the hour, and just really want to thank both of you, Shiva and John, for joining us.